Hello, everyone. This is Megan Leo. I'm the ultrasound director here at BMC. We're very excited to have you. So I'm going to bring you through what is the first flipped classroom portion of our PGY1 orientation. So our first topic is going to be on ultrasound physics, a kind of a dry subject, but actually really important to understanding how to best use ultrasound for your clinical care. So we'll bring you through just the important points here. So our objectives today are going to be to look at just kind of basics of how ultrasound works, some of the different probes, why you choose them, some of the more important functions of the ultrasound, including M mode, B mode, Doppler, some of the important knobology, which is actually how to turn the machine on, how to enter data, how to adjust your screen, etc. And then also some important artifacts in ultrasound, which even though you would think artifacts are things that you don't want, artifacts are actually very important for both diagnostic reasons and for troubleshooting and optimizing your image. So just a quick note on the goals of our bedside clinical ultrasound, limited ultrasound, whatever you decide to call it. What's important to understand with this is that we're not radiologists, we're clinicians. We're using ultrasound to answer brief and important clinical questions. We want them to be goal-directed, focused, and really the purpose of the ultrasound is to help us take better care of our patients and treat them with the right medicines and also guide us to the right diagnosis. So just some ultrasound basics. So quickly, ultrasound basically is converting electrical energy into mechanical pressure waves that then travels through tissue or any sort of medium, and the propagation occurs because of what's called compression and refraction. So just to put this in perspective, our human ear can hear sounds anywhere from 20 hertz to 20 kilohertz, and ultrasound is above that 20 kilohertz. That makes it the ultra part of sound. And that, as you can see on the screen here, that's along the lines of what bats and dolphins can hear. So this is really high frequency sound, and not typically what we would hear on that spectrum. This is the diagnostic level of sound waves. Now there's even higher frequency sound waves that are used that are actually more therapeutic. But we won't talk about that today. So just a little bit more on this. Basically, you're talking about wavelength as the inverse of frequency. And the reason that's important is because every time you increase your frequency, you're compromising on your wavelength. So there's a trade-off between the resolution of the image and the depth with which it can visualize, and then on the inverse as well. And that we'll get into that a little bit more when we talk about probes. That's why that's important. And then as we go along, just remember the terms attenuation and intensity. So attenuation is as sound propagates through tissue, there's going to be some loss of energy as it travels through tissue and as it travels back, and that then manifests as the intensity of the sound wave that returns, which is then projected on the ultrasound screen as a various degree of bright dot. So the reason this all can happen is because there are these crystals within the probe that have a property called the piezoelectric effect. It is what has the ability to convert electrical energy, or the energy from the plug in the wall, to the mechanical sound wave energies. And just as a kind of minutia thing, but if you continue to get interested in ultrasound, this tends to be kind of a number that people remember. So speed of sound wave through tissues tends to be about on the order of 1,540 meters per second. So here again is some of the important properties of ultrasound. So you have absorption, which is going to if you absorb everything, then nothing is going to be reflected back. Reflection then is reflecting off the object. That's how we get our picture. And then scattering is also going to be something you see with some matter that doesn't allow the sound wave to travel back in a straight line, so that might be things like air. And then there's refraction, which you can see the sound waves sort of reflect off at an angle as opposed to coming straight back to the ultrasound probe. So here we go again talking about the compromise between high frequency and low frequency. So shorter wavelengths, you're going to have a better resolution, but you're not going to be able to penetrate as deeply. So this is going to be for more superficial imaging, musculoskeletal procedures, etc. And that's going to be your linear array probe, which we'll show you a picture of in a second. And then on the flip side, if you're wanting deeper penetration, like into the abdomen, you're going to want to choose a lower frequency probe that has a longer wavelength. So again, that penetrates deeper into the body, but you'll have a little compromise on resolution for imaging those deep structures. So the linear array probes displayed here, this is going to be for your procedures, musculoskeletal. This is a high frequency probe that gives you nice clear detail. The curvilinear probe is going to be for body imaging, so this is what you're going to use for your fast and gallbladder, kidneys, anything that kind of images deep into the body. And then lastly, your phase array probe, which is somewhere a bit in the middle, but this has a nice small footprint. This is going to be used for your cardiac imaging. It has good penetration, but also has a little better resolution than the curvilinear probe. So in order to allow our sound waves to propagate, we need a coupling agent. So typically this is going to be your gel. You can also use a water bath, which is displayed on the image on the right. And this is going to allow the sound waves to travel from the probe surface to the skin. Now, in general, by convention, you want to identify the probe marker, which will be a notch or a line on your probe, and that's going to correspond to a dot or reference point on the screen. In general, you always want to have your probe marker to the right of the patient or to the patient's head. Now, this is just an important point to know. Ultrasound is a very safe imaging modality. We don't really think of it as causing any sort of damage to tissue whatsoever. But there is something to consider as far as the energy of the sound waves and the heat it produces as it propagates through the cells. So there's a term called ALARA, which is as low as reasonably achievable. This is a concept in which you want to use your ultrasound to get your images, answer your questions, but you really don't want to spend a long time exposing the patient to the sound waves. And then also you want to consider the different functions of the ultrasound machine because they do have different amounts of energy. This will become even especially more important when we talk about imaging the eyeball or fetal tissue. Those are the most fragile tissues in the array of things that we image, and you want to make sure you're exposing that tissue for the shortest amount of time and with the lowest energy mode as possible. So the different modes we're going to talk about are B mode, M mode, and Doppler mode. So your B mode is basically B for brightness. This is just talking about the gray-white image you see on your machine. So those sort of the white and black shades on that screen, that's all a reflection of the intensity of the sound that is coming back to the probe and then processed as an image. So strong reflectors are going to return strong signals, so there's very little attenuation, little absorption off of that object that it reflected off of, whereas weak reflectors are going to absorb more of that sound, and the sound that actually returns to the probe is going to be weaker. So that's going to be displayed accordingly on the screen, and that's where we get our terms of hyperechoic, isoechoic, and hypoechoic. So hyperechoic is going to be a very strong reflector. It's going to come back very bright. So those are things like bone, diaphragm, pericardium. Whereas on the contrary, hypoechoic are very highly absorbing matter, and that's going to include things like blood, ascites, urine, and those are going to show up black on the screen. And then isoechoic is going to be somewhere in the middle, and that's typically your muscle, liver, kidney tissue, sort of more on the gray scale of things. So here's an example of all three of those, really. So this arrow that's already there is displaying a very hypoechoic structure. This right here is the diaphragm, and that's a very strong reflector. You can see how bright that is. And then right here is a spleen, and that is more on the spectrum of a isoechoic, so along that gray scale. Here again is a rib. That's going to be a pretty strong reflector, so behind it you're going to get some shadowing, which is again, not going to display any return sound to the machine. All right, so that's an example of that. So this brings us to talking about gain. So gain is the sensitivity of the machine to receiving echoes. So there's a lot of background scatter and a lot of information that comes back to the machine. And with all of our sophisticated technology, those machines then filter out some of the echoes that seem to be more artifact than real reflectors. So this is gain. So the overall gain will increase the overall sensitivity of the machine to receiving the echoes, and then the time gain compensation actually looks at near gain, mid-screen gain, and far gain, and I'll show you that in a second. So this is an example of an undergained image. You see how kind of black that is. That means the machine's really only showing the more strong reflectors, and but there's a compromise here, so you're not getting as much information from that image. Now here's an overgained image here. You see how bright that is. So you can see structures a little bit better there, but the increase in gain is actually not allowing us to contrast the different structures that well. So you want to find a compromise between the two there. So here's our spark machine. We'll go through our knobology a little bit more later. But right here is our time gain compensation. There's 3 lines there that represents near, mid, and far gain. And you can adjust each of those. So if something's really bright in the far field, you can decrease the gain at that portion of the screen. And likewise on the other end of things, if things are very dark in the far field, you can increase the gain so that you can see it a bit better. So here's an example where you may want to do that. So this is a bladder. This is posterior acoustic enhancement. So you can see, sorry, I'll go back here. You can see how, sorry about that. You may want to decrease that far gain because it was so bright. So you can do that by decreasing, it would be the far gain there. So again, this is your posterior acoustic enhancement. This is your bladder. So you would decrease that far gain there. All right, now next is M mode. So this is looking at motion over time. So we use these for heart rate assessments. You can also use this for IVC motion. We'll talk about this a little bit more, but basically it's looking at along this line here on the screen, looking at the grayscale or M mode imaging along that line as a function of time. So that's displayed down here through the x-axis is the time there. So here's an example of somebody taking a fetal heart rate. So you line up your M mode, run it over time. There's a little flicker there that's going to display the heart rate, and you can see right here there's some little flickers. And to get your fetal heart rate, you may zoom in here a little bit. You may push the calc button, go to fetal heart rate. You would take your first marker there. We do a 2-beat peak-to-peak measurement, so we'd skip our next one and then go to our next flicker here, and that'll give us a heart rate. Okay, and lastly is Doppler mode. So this is going to be looking at direction and speed of either blood flow or tissue motion. There's various different kinds of Doppler, color, power angio, spectral, continuous wave Doppler. We're just going to talk about the top three very briefly, just so you get the concept of what they are. So color Dopplers are most common. We're going to look at direction of flow. This gives you a relative velocity based on that color scale over here in the corner. You can see this is flow towards the probe, this is flow away from the probe, and the intensity of the color will tell you the relative speed. So very light red will be faster, very light blue will be faster in the other direction, etc. So this is your kind of standard vascular kind of assessment. And then power angio does not look at direction, so it allows you to pick up lower flow states, and also does give you a relative velocity based off of the intensity of the shading of the color. So again, very light is going to be much more fast, but that is best for things like this is a ureteral jets in a bladder. And there's various other things you can use this for, but remember that it's independent of direction, so it gives you a little better assessment of lower flow states. And then lastly, spectral Doppler. This is looking at actual quantitative velocity, so it's going to give you a true speed. Now the limitations to this is that there is a Nyquist limit, which is basically if you have such a fast velocity that you're coming off the screen, you may get an aliasing, which then will display up here, sort of reflects up. So that's just the limitation to this. But you mainly use the spectral Doppler in cardiac imaging if you're looking at diastolic dysfunction or perhaps in leg veins if you're looking for DVTs, things like that. All right, so the last part that's actually pretty important is artifacts. We're going to go through this somewhat quickly. So shadowing is an important artifact to review, mirror artifact as well. And then posterior acoustic enhancement we talked about a little bit off the bladder, and then reverberation. So shadowing is going to be off of a very strong reflector is going to have shadowing behind it. So those are things like rib shadows, gallstones. I guess some solid tumors can cause that as well. So here's an example of some gallstones. So you can see that the stone is quite a strong reflector. It's very bright at the top part of the stone, and then there's this shadow just behind it that is black. So that is an example of shadowing. So the next image we've talked about already, so I'll kind of move fast past this. This is just posterior acoustic enhancement. So that's this bright white imaging and the bit behind any sort of low attenuating matter or things that aren't going to reflect back very strong. So you're going to end up, these are going to be things like bladder, urine-filled, fluid-filled things. So abscess, any cystic structure, you're going to see posterior acoustic enhancement. And that's sometimes very helpful because it helps you identify something as being fluid-filled versus solid, like tumor-like, or especially when you're assessing abscesses. Sometimes with MRSA abscesses, they'll look more isoechoic, and if you see that posterior acoustic enhancement, you can tell that it's fluid-filled and that you should probably drain it. Mirror artifact is, we talk about this a lot in the right upper quadrant. This happens when there's an adjacent strong reflector. The diaphragm is a very strong reflector, so then this produces a false image deeper to the reflector. So I won't go into too much as to why this happens, but basically your machine interprets sound as always going down and back. And off of a strong reflector, you actually have sound come down off the diaphragm. It refracts off into the liver, comes back, and then goes back to the machine. But the machine thinks that this sound came down here and came back. So it basically puts the liver tissue image posterior to that diaphragm. And the reason that that's so important for this right upper quadrant image is because when there is no fluid up in the pleural space, you're going to get that mirror image. So there's something called the spine signal. So this is the spine here. You can see how it just stops at the diaphragm. Whereas if there was fluid up here, this spine signal would actually project above the diaphragm. This would all be black, and you would actually be able to see the spine behind the diaphragm there. Okay, and then lastly is reverberation. So I kind of joke with the interns and the med students that if we're ever asking you for an artifact, just say reverberation, because that's probably what it is. So this is a very common artifact. We see it off of the lung tissue. It's what causes beelines and comet tails. We also see it off of air. We see it off of metal objects, so foreign bodies. And here's an example of beelines. You can see that this is the pleural line here, and then this bright white beeline here is a reverberation artifact that's coming off of that pleural line. And you kind of see something similar when you're imaging metallic objects. So this is an example of a IUD, a metal metallic IUD, and you can see that there's kind of some bright white repeating lines off of that metallic object. That's a reverberation artifact. All right, so we're in the last part here. Thanks for bearing with me, everybody. So just some quick stuff on the buttons of the machine. So we'll go over this a little bit more with hands-on, but to get started, you want to be coming into your screen here. This is the sleep button. Hopefully the machine is on, and you can just push this moon and the screen will wake up. Otherwise, this is the on-off button. It takes the machine like 2 or 3 minutes to actually warm up. So in general, we leave the machines on and then just put them in sleep mode. If you want to get started, you can push the start end button. That'll allow you to enter the patient information. We have barcode scanners, so you can just scan the patient's wristband. And then you put your last name into the last name section, so we know that it was you doing the scan. Here's your transducer button, so that's going to allow you to pick the probe that you want. It'll default to an exam type, but if you wanted to change it, especially if you're doing OB scanning, you're going to have to change the exam to pelvic. Get yourself set up into the right preset there, and then you can start scanning. Just some other important buttons here. This is your depth button. That's going to allow you to adjust the screen. Here's your gain that we talked about. In general, you probably won't have to change this overall gain, so don't worry about that too much. But here again is that time gain compensation, so you can make your near image a little bit brighter, make your far image a little less brighter. Adjust your screen that way. Here are your Doppler settings up on the top of the screen. You also have your calculation button down here, measure button, and probably the last two most important keys are down in this area. So we've got your acquire button that allows you to take a clip of the video, and then here's your freeze button, which allows you to freeze the image, maybe take a measurement, and then when you press acquire, with the image frozen, it'll take a still image of that. All right. So that's pretty much it, everybody. Thanks for bearing with me. We are hoping that we're going to bring all of you up to the level of these excellent BMC Sono Games champs here. We've had a good run of it. This is our team from this past year who made it into round 2 finals, and we've got a legacy of a couple championships a few years ago, so we really want to bring this back home. All right, everybody, thanks.